Hello, my name is Patricia Pearson, and this is a presentation of my DMP project, an evidence-based clinical practice guideline for fiber education in an endoscopy lab for Maryville University. My project committee is Dr. Gail Petrov as my chair, Dr. Maria Snell as my second reader, and Dr. Emily Mawkins as my community member. The background and/or significant information for this project began with a clinical observation. I'm an endoscopy nurse and I care for patients in the pre-op, intra-op, and post-op settings in an endoscopy lab. And I noticed that many patients with constipation and GERD were encouraged to follow a high fiber diet as part of their care. However, I learned that they lacked knowledge of dietary fiber. When questioned about fiber diet, they would report eating minimal fiber, and minimal fiber education was provided to the patient in the endoscopy unit. Education usually ended with eat a high fiber diet. So this led me to start asking questions to my patients and ask them what foods were highest in fiber. Specifically, do they know some of the highest fiber fruits, highest fiber vegetables, or highest fiber grains? And then I would ask, do you know how much fiber that you should consume in a day? Many patients had no idea which foods were highest in fiber and had no concept of how much fiber they should consume as part of their daily diet. So this observation led me to conduct further research, and I found that fewer than 10% of Americans consume the recommended daily fiber. In addition, about 20% of the population has gastroesophageal reflux disease or GERD, and about 15% experience constipation, and this prevalence increases with age for both of these diagnoses. So a high fiber diet can reduce symptoms of constipation and GERD and improve overall quality of life, but people need to understand what a high fiber diet is, which foods are highest in fiber, and how much fiber they should be consuming in a day. After identifying this gap in care, it was questioned whether implementing a clinical practice, an evidence-based clinical practice guideline that standardizes fiber education for patients presenting in the endoscopy unit for procedures who are experiencing constipation and GERD symptoms could improve fiber knowledge and dietary fiber intake. So I went to work. Clinical practice guideline was developed for endoscopy nurses in the pre-op screening of patients who are presenting with constipation and GERD symptoms. So for pre-op screening, when patients come in, they are always asked, why are they presenting for the procedure? Like, why are they coming to do that procedure that day? And if they're coming in with constipation or GERD symptoms, they can be evaluated for their fiber intake or followed up with their fiber intake. A fiber handout is included with information of types of fiber and ways to increase fiber in the daily diet. And additionally, a fiber worksheet with fiber goals, high fiber foods, recommended fiber intake, water intake, and exercise using USDA recommendations is also provided or followed up upon. So as GI providers will also be using this education worksheet, the worksheet can be used for fiber tracking. It also offers apps to help track fiber and offers resources to check fiber counts in other foods that may not be listed. So again, what happens as far as the process goes, the GI providers and the endoscopy unit will all be using the same education. So when patients are coming into the endoscopy unit and they're being asked why they're having the procedure, it gives the pre-op screening nurse the opportunity to ask questions to symptomatic patients about what their fiber intake is, ask about a diet journal, offer the fiber education for the first time, or follow up with fiber goals or education that has been provided by the GI providers. So this individualized fiber education used by both GI providers and the endoscopy nurses promotes continuity and collaboration of care. So a clinical practice guideline was developed with the aims to standardize fiber education in the endoscopy unit and GI office. Currently, there are no clinical practice guidelines for the endoscopy unit regarding diets specific to disease process or symptoms. So the education is usually a general pre-post procedural diet, such as return to previous diet. So, and currently, all GI providers use different fiber education for patients, and it lacks fiber goals and guidance on gradually increasing fiber and then specific foods highest in fiber. Other aims of the clinical practice guideline is to increase patients' dietary fiber knowledge, increase patient dietary fiber intake by making preventive dietary education a healthcare priority, reducing constipation and GERD symptoms, and overall improve patients' quality of life. So given these aims, A literature review was done. The search using Maryville's online library database and Google yielded articles for this project. The search was limited to the English language, full text, peer-reviewed primary research articles within the last 5 years. And that included 2018 to 2025, as this research originally began in 2023. So keywords included different variations of fiber, constipation, GERD, and diet, Boolean combinations such as constipation or GERD and high fiber diet, fiber and education, and constipation and GERD, and constipation or GERD and diet modification were all used. I also included my nursing theory along with these words, word combinations, and search for articles supporting the application of the nursing theory. There's a hierarchy and levels of evidence based on strength of the research design, with level 1 being the strongest level of evidence. And due to the greater confidence in findings and reduced risk of bias, that would be level 1. So, however, the level of evidence, the quality, and the consistency of the research must all be considered. So, looking at that level of evidence, and then also looking to each article that was used was evaluated using the Joanna Briggs Institute or JBI appraisal tool. The JBI has specific checklists for each type of study design. So the checklist questions address methodological quality, including bias, reliability, validity, and appropriate statistical analysis and outcome relevance. So using this tool and process helped determine the quality and applicability of the evidence to support my clinical practice guideline. So 10 primary research articles were included in the literature review. The range of methodological strength included 2 randomized controlled trials, 2 quasi-experimental studies, and 6 level 5 cross-sectional studies. Although the majority of the evidence was level 5, the inclusion of the randomized controlled trials and quasi-experimental studies strengthened the overall evidence. The clinical practice guideline was supported by the consistency of findings across the different study designs. So after all of this was done, the list, in addition to the clinical practice guideline, the list of articles along with the levels of evidence and the literature review with the application to the clinical practice guideline was provided to all the stakeholders in writing. The themes revealed by the literature review were diet impacts constipation and GERD. There are common food triggers and dietary habits such as processed foods and that impact constipation and GERD symptoms. Increasing dietary fiber intake decreases constipation and GERD symptoms. A high fiber diet can reduce symptoms of constipation and GERD. It was found that adding 2 kiwi per day or 5 grams of fiber per day can improve constipation or GERD symptoms and quality of life. In my experience, it is common when it comes to dietary education, the focus a lot of times is on what foods to avoid and not what foods to add. And so this is one way that can be change how we present dietary education, because we're going to be talking more about foods that can be added instead of what to avoid. So fiber education can improve fiber intake. As providers, we need to make sure that the education is effective and patient-centered. For example, if we tell a patient to eat a high fiber diet that includes whole grains such as oatmeal, and the patient really hates oatmeal, that may not be the most effective approach for that patient. So with that being said, the theoretical framework for this project was Imogene King's theory of goal attainment. King's theory explains that a person has their own beliefs and perceptions shaped by groups and interpersonal systems, such as family, friends, and work, and then the broader societal symptoms. And then additionally, the person's belief also interacts affecting the interpersonal and societal systems as well. So King's theory explains the processes of action, reaction, interaction, and transaction in the nurse-patient relationship for mutually setting health goals and developing a plan to achieve them. The fiber education for the clinical practice guideline is designed to help the patient understand fiber, how much fiber is needed, what foods are highest in fiber, and to be involved in setting fiber goals. This education is patient-centered in that the fiber goals can be varied on patient intake or preferred foods that they enjoy. So approaching dietary education with the nurse and patient collaborating on mutual goal setting helps improve patient health outcomes. So this brings us to the methods and design for this project. The project design was to develop an evidence-based clinical practice guideline, which was appraised by stakeholders in the endoscopy unit. At the time of the project, there were no current clinical practice guidelines or standardized diagnosis-specific dietary education provided by endoscopy nurses. The agreed-to instrument was chosen to guide clinical practice guideline development and appraisal due to its validity, reliability, and its evaluation of methodological rigor. This instrument is used worldwide for healthcare clinical practice guidelines. The agreed-to instrument comprises of 23 questions or items divided into 6 domains. The domains are scope and purpose, stakeholder involvement, rigor of development, clarity of presentation, applicability, and editorial independence. So with these domains, you can see from the bar graph that the rigor of development is a priority as reflected in the number of items addressed for clinical practice guidelines, emphasizing the importance of the systematic and evidence-based development. The instrument was provided to volunteer stakeholder appraisers along with the clinical practice guideline. The appraisers used the instrument to appraise the clinical practice guideline on a 7-point Likert scale, with 1 indicating strongly disagree and 7 indicating strongly agree. The appraisals were then collected and the data was transferred to an Excel spreadsheet. So data analysis was performed using the agreed to instruments instructions. Each item has a section for comments in this project, or I'm sorry, as a section for comments. So for this project, the comments, the majority of comments were the appraiser notes or support for the clinical practice guideline or recommendations for future research. So the qualitative data was reviewed. However, it was not included in the results per the agreed to instructions. This is a brief overview of the project design. As I mentioned, this project process began in August 2023 with assessment and planning. Literature review was done. Approvals, including IRB approval and exemptions, were obtained from hospital management, the hospital site, project chair, and Maryville University. Then guideline development in December of 2025 and the spring semester of 2026, data collection in May of 2026, and then results and finalization of the clinical practice guideline with presentation to stakeholders in June and July of 2026. So for this project, there was no sample as human subjects were not studied. Volunteer stakeholder appraisers in various roles in direct patient care were the clinical practice guideline appraisers. So inclusion criteria for appraisers must be at least 18 years of age, currently working in the organization, provide patient care or oversee patient care in the endoscopy unit, provide patient care in the gastroenterology or bariatric offices, having the authority to order procedures in the endoscopy unit. The 7 stakeholder appraisers consisted of 2 physicians, a nurse practitioner, and 4 nurses. The stakeholders provided ordinal data, which were collected and analyzed per the agreed to instructions. The appraisers assigned scores to the 23 items across the 6 domains using that 7-point Likert scale. Each appraiser's item scores for each domain were added and then added to give a domain score, and then the appraiser's domain scores were added to overall domain scores. So here's a bar graph showing the maximum and awarded scores for each domain for the project's clinical practice guideline based on the agreed to instruments scoring with 7 appraisers. So as you can see, the clinical practice guideline awarded scores were in close relation to the maximum possible score. The awarded domain scores were then used to calculate a scaled domain score. So the scaled domain scores were percentages that were compared to a predetermined domain score. The scaled domain scores are used to identify strengths and weaknesses of the clinical practice guideline. The agreed to instrument allows for variation in determining which domains are priority. So some clinical practice guideline appraisals will only use some of the domains. Additionally, the instrument allows for predetermined scale domains to vary. So those, the predetermined scale domain could be higher or lower. So for this project, all 6 domains were included, and the predetermined scale domain for each domain was greater than or equal to 85% for the clinical practice guideline to be adopted into practice. So here are the results of the scale domain scores for the clinical practice guideline. All scale domain scores exceeded the predetermined threshold, supporting the guideline's quality and acceptability. They range from 91 to 98%, demonstrating consistency across all six domains. So I've listed at the bottom of the slide how the scores were calculated. For this clinical practice guideline, no revisions were needed, and it is appropriate for use in practice. Additionally, the average scale domain score was 95.3%, with the standard deviation of 2.9%, indicating little variation among the scale domain scores. The final questions of the agreed instrument address the overall quality of the guideline and recommendations for use. The overall quality is rated using the 7-point Likert scale, with 1 indicating the lowest possible quality and 7 indicating the highest. The last question addresses recommendation for use with the possible answer of yes, yes with modifications, or no. And as you can see, the overall quality scores are 6 or 7, and the stakeholder appraisers, all of them recommended the guideline for use. The limitations of this project were the demanding workflow and increased patient volume, which created barriers for some interested stakeholder appraisers, and limited their availability to participate. The goal for this project was to have at least 10 appraisers. However, according to the agreed to instrument, 2 is acceptable, but at least 4 is recommended to ensure the guideline strength. Although the goal of 10 was not reached, the number of appraisers exceeded the number of that were required to meet the agreed to instruments evaluation criteria. The limited time decreased motivation to change and participate in the project. This was overcome with words of encouragement and short meetings called huddles with the staff to discuss how they can participate in the project's implementation and what it looks like for the unit. So the timing of this project limited management involvement in the appraisal process. However, they will have the final implementation authority for the clinical practice guidelines, so they will be reviewing the results, and so therefore these key stakeholders still remain involved in the clinical practice guideline appraisal process. As far as discussion, all scale domain scores exceeded the preset threshold, supporting the guideline's overall quality. Every appraiser recommended implementing the clinical practice guideline, indicating a strong stakeholder support. Finding support implementing the clinical practice guideline in the endoscopy unit. And these findings are consistent with existing evidence supporting standardized fiber education to improve fiber knowledge and fiber intake, reduce constipation and GERD symptoms, and improve overall quality of life. As far as implications for practice, this clinical practice guideline empowers the endoscopy nurses in the unit to be leaders in health promotion and disease prevention. It empowers endoscopy nurses to become leaders in their specialty. It encourages collaboration of care and continuity of care with the GI providers. Everyone in both departments will be using the same educational information and worksheet. It provides a standardized care that is patient-centered, and patients and nurses or providers will discuss and set fiber goals with patients' preferred foods. It may improve fiber intake for patients. It helps close a fiber knowledge gap for patients presenting to the endoscopy unit with constipation and GERD symptoms, and provides a foundation for future guidelines for fiber education in other areas of the hospital, in endoscopy units, and for fiber education for other disease processes. The impact of this project has been rewarding, with changes in healthcare that improve nursing morale, empower nurses, and enhance patient care. One thing I would do differently is to develop a team within the department for the appraisal process. This may have improved overall continuity of involvement with the staff and reduced my stress, knowing how many stakeholders would appraise the guideline, and allowed also for a little bit more flexibility. After completing this project, I have gained strong appreciation of quality improvements, such as clinical practice guidelines. They impact the overall quality of care and nursing morale, empowering nurses to work to the fullest potential and see how doing so makes a difference in patient health. So I look forward to creating other guidelines and being a part of other quality improvement projects. Specifically related to this project, I would like to be a part of research evaluating the short-term and long-term effectiveness of fiber education. This DMP project has improved my ability to evaluate and synthesize evidence and improve my leadership skills to drive practice change. Overall, the DMP project and program has inspired and equipped me for future leadership and research. And I appreciate all of the Maryville staff who are involved in supporting me throughout this journey. These are my references. Thank you. And I've added my email. If anyone has any questions, feel free to email me. I also included a QR code that is linked to my clinical practice guideline. So if anyone wants to actually take a look at the clinical practice guideline that was presented to stakeholders, that is available. And that's all I have. Thank you.